All right, welcome. I hope some of you learned something today because a lot of what I'm going to say is pretty elementary, and a lot of it was discussed very well by other participants earlier this morning. So my job is Blood Culture Workup 101. This is our maiden voyage into breakout sessions. We've been talking about doing breakout sessions for like 5 years, even before coronavirus. And this is the first year it's actually happened. So if any of you have ideas for other breakout sessions in the future or any feedback of any sort, if it sucked, if it was good, please let me know. I'm open to, Lauren knows I'm open to any kind of commentary. So this is kind of the outline we're going to handle. We might get a little bit more into pathogenesis of sepsis versus what may have been discussed earlier today. We'll talk about specimen collection just a little bit. We'll probably skip over that because we had a wonderful panel session on that, and then we'll get a little bit more into culture analysis. I might be able to shed a little bit more detail into some of the thoughts that were going around in some of the breakout sessions before. I'm totally informal, as of course Lauren knows, so if you have a question, just stop me at any time. If I don't make it through all these slides in 45 minutes, that's fine too. So be as engaging as you want, I don't care. All right, pathogenesis. Okay, so this is a very simple schematic of the immune system, right? So blood culturing, detection of organisms comes into play when all these defense mechanisms are breached, right? So at a very basic level, the immune system can be broken into innate immunity on the left and adaptive immunity on the right. Your adaptive cells are kind of your lymphocytes or your memory type of cells. Your innate defense mechanism can be broken into external defense mechanisms like mucociliary, escalator, all sort of competition for binding sites. And then your internal defense mechanisms, once it gets past that stuff, can consist of cellular mechanisms or acute phase reactants. Your cellular innate immune cells are like your granulocytes, maybe your dendritic cells, your antigen-presenting cells, and your acute phase reactants are like your complement system, your procalcitonin, we heard about that. So lots of things actually combat organisms when they hit your bloodstream such that you may not get a true bacteremia or a true sepsis, right? But when that is breached, we start getting into clinical definitions like bacteremia, septicemia, and endocarditis. And I'll speak to each of those in a little bit, right? So simply stated, bacteremia is the presence of bacteria in the blood. We're not talking about clinical symptoms at this point, signs or symptoms. It's simply presence of bacteria or fungus in the blood or yeast in the blood, which would make it a fungemia. Two basic sources for that. Number one, direct entry into vasculature down at the bottom. This might be your contaminated needles, maybe a traumatic implantation instance. Probably more of your sources of bacteremia is going to be drainage from a primary focus of infection, right? So when an ID consult happens for a positive blood culture, not only do they want to manage it with the appropriate antimicrobial agents like our pharmacist friends talked about before. Where's Heather? There she is. But they're also going to look for the source of infection or the nidus of infection. Where did that bacteremia come from? Was it a UTI antecedent? Was it, oh, there's Deb. I've known Deborah for a long time, and it was very rewarding to see her up there. And you did a great job talking, so we appreciate you. So could come from a primary focus of infection. Is there a UTI that's antecedent to your bacteremia? Does the patient have a pneumonia? Does the patient have an abscess? Do we have to go hunting for something? Do we need imaging to find that, right? Do we need to drain something or take something else? They're always looking for the primary focus of the infection as well. And then grades of bacteremia. We have transient bacteremia, intermediate, and continuous, right? So at about 4:45 this morning, I probably gave myself a transient bacteremia, meaning when I brushed my Goombas this morning, exactly, right? I probably introduced normal oral flora into the bloodstream, giving myself a transient bacteremia. And if I have really good innate immunity and or adaptive immunity, it's going to clear it pretty quickly. So the transient bacteremia doesn't last very long, and the immune system pretty much handles it pretty well. Intermittent bacteremia is probably a little bit more serious. There are conditions like osteomyelitis or bone infection or maybe a focal pneumonia that sheds or seeds the bloodstream with organism, stops for a while, sheds the organism in the bloodstream, same organism, stops a while, same organism gets in. So that's called an intermediate bacteremia. And then continuous bacteremia is probably the most serious, and we'll kind of correlate that with positive blood cultures in a little bit. Infectious endocarditis is when you have a continuous seeding of the bloodstream with an organism. Brucella in its early status or states can do that, as well as typhoid fever. Remember Salmonella serovar typhi, capital T, no italics, is actually a bloodborne disease more than a Hershey squirts type of disease. Okay? Then we get into septicemia or sepsis. This is when the bacteria in your blood starts giving you signs and symptoms of infection, right? This is probably the far more serious illness than, say, the bacteremia. So Heather, I think you cited data about sepsis in the United States in your talk. My data is actually a little bit higher because it actually incorporates, I think, some of the COVID-19 patients into that, right? So government agencies cite a 40% increase in sepsis over that report in 2016, largely owing to all those COVID patients we had in 2019, 2020, or whatever with that, right? About a 15% mortality rate in the data I cite, very similar to what Heather cited this morning. It's estimated that about 10% of all hospital expenditures in the United States are due to sepsis, to the tune of about $52 billion. Sepsis can largely be characterized by you're changing your vital signs, right? Hypotension, although I think one of the cases this morning mentioned hypertension as well, but decreased blood pressure, being febrile, tachycardia, heart beating too fast, tachypnea, you're breathing too fast, increased respirations. And some of these 4 vital signs or changes in vital signs can actually be antecedent or come before the actual clinical diagnosis of sepsis. This might be what brings you to the big house in the ambulance to begin with, okay? Many cases of sepsis are related to endotoxin. If you think back to your gram-positive and gram-negative architecture, this makes sense, right? So gram-negatives have lots of LPS in their cell wall, right? Gram-positives don't. They have teichoic acid and lipoteichoic acid, but the LPS in gram-negatives is very significant because the lipid A of LPS is a very strong immunogen, right? And most of the nasty reactions that have in a patient due to sepsis are due to your immune system, which Nate's probably talking about right now in the other room, right? So it's actually in a huge immune response to the LPS that largely brings about your sepsis. And then when people get really bad into septicemia, they could go into shock, right? And one of my students taught me the 2 differences in shock: compensated shock versus decompensated shock. She's actually an EMT, so she's seen this live, and it's wonderful to have students who've seen this stuff before out in the field because they can educate the educator. And Deb's going, yeah, I've seen that before too. So in compensated shock, there is a peripheral vasoconstriction. That means that the vasculature peripheral is being constricted to devote blood flow to your important organs, your vital organs, such as the brain, heart, liver, and kidneys, right? So you have normal blood pressure overall because of that vasoconstriction, but as a result, you get the blue tinging of the lips, you get pale, cool skin because everything's being devoted to your core, right? In decompensated shock, that's the really severe case in which you have decreased blood pressure all around, you have failure of your vital organs, and that's despite being given lots and lots of boluses of fluids, right? So despite bolus amounts of fluid resuscitation, you still have that decreased blood pressure, and that's called decompensated shock. Any questions so far? Am I screaming too loud? Everybody hears me okay? All right, I'll try to calm down here. So here's an audience participation thing, right? So here are rates of sepsis in the United. Here are rates of hospitalizations relative to sepsis in the United States. There is an orange bar that appears to be higher, or an orange line that appears to be higher, and there's a blue line that appears to be lower. So as the lady said, the difference lies in the preposition. One of these lines is hospitalizations for sepsis, and one of these lines is hospitalizations with sepsis. My challenge to you is to match the preposition with the color. Who wants to stick their neck out and tell me what the orange line is, with or for? Because the difference lies in the preposition. Don't think too hard. I know you just had lunch. You're going into the food coma right now. Which line is 4? Lauren, you say 4? I'm going to say that the blue line is 4. What would be the difference? Person in the back, you're nodding. Oh, just watch me.
My thought is that you're already in the hospital and you develop sepsis, right? So you have sepsis.
Oh, we're going to ask you to document your findings using a microscope. Not a microscope or a microphone. This is only for archival purposes. I can hear you just fine.
Okay, wait. So you said we said 4 or with? So we said
I'm going to contend that the blue line is
With
for
4.
sepsis.
I
Yes.
agree with you.
Why?
Because I would think that most people can develop other problems when they're already in the hospital, like MRSA,
Exactamundo.
sepsis, all this stuff.
Yep.
And whereas like when you come in, usually people that come in with sepsis like through the ER are like, oh shoot, like last resort, you know.
Right.
So that was my guess.
So the blue line is when you have your change in vital signs. You're coming into the big house on the ambulance after you take your one pill that you found in the cupboard from 30 years ago, right? But as folks are hospitalized for other conditions other than sepsis, they obviously could develop sepsis while they're in the big house, right? So that would be the with sepsis in the orange line. And of course, a lot of these come, unfortunately, from nosocomial infections, right? You're in there for a fake hip or something like that, you develop sepsis while you're in the hospital, right? So same thing down there. So your general sepsis rates or your percentage of inpatient stays is chronicled at the bottom. So we nailed that one pretty well. Good job. So in general, as a person ages, the rates of hospitalization for or with sepsis increase as well. So folks under the age of 65 have a generally lower rate, but as 65 seems to be the big threshold for increased predisposition to sepsis. You see from the blue and green bars that there's a pretty equal gender distribution for sepsis in the United States. Then my last one, average length of stay for those with septicemia or sepsis versus other hospitalizations. The bean counters go crazy over this one because there's a lot more hospitalization days relative to sepsis versus other conditions. All right, any questions on bacteremia or sepsis before we move on to lub-dub? All right, endocarditis is an infection of the heart valve. You can have prosthetic valve endocarditis, and you can have native valve endocarditis. And Lauren knows that there are different organisms that are associated with prosthetic valve endocarditis versus native valve. Do you want to give me one, Lauren, that's more associated with she's one of my past students. And I love to pick on her when she was my student. It's even better now. How about ones that form biofilms, like coagulase negative staph, right? So if you have hardware or fake stuff in you, biofilm producing organisms love to stick to plastic, and of course coag negative staph is one of those. Native valve endocarditis, that might be one of your Hayseck organisms or one of your normal flora organisms getting into your bloodstream, seeding your heart valves, so on and so forth. So symptoms of endocarditis include fever, chest pain, murmur, you're kicking off an emboli here or there, or petechiae. Petechiae are when those small emboli kind of localize to extremities, destroy capillaries, and then you get these petechia formation. I'll show you an image of that on the next slide. Acute and subacute. Acute is probably more to your pathogenic organisms or the organisms less likely to be normal flora, right? So this would be maybe an E. coli coming up from a UTI causing an endocarditis versus subacute, which are your normal flora organisms, like your Hayseck organisms. Everybody remembers their Hayseck organisms? Raise your hand if you know your Hayseck organisms. Uh-oh. Oh my God, somebody just went, oh my God, in the back row. If we have time, Deb is going to tell us what our Hayseck organisms is at the end of the lecture. I'll try to keep that in mind. All right, so here we go. Petechiae. So these are those little reddish spots, usually at your extremities. And of course, when your ID physician comes in on a consult, they're looking you over everywhere, right? Lift up the sheet, you're checking out the fingertips, you're checking the toes. Whoops, there goes my microphone for recording purposes only. There's also petechiae that may be seen in the conjunctiva, such as this individual right there. So that's the petechiae. That's evidence that something is being thrown potentially from your vegetation. Now, there's the word vegetation. So endocarditis often presents as vegetations on the heart valve. Here's the typical heart valve material. I'm assuming this is autopsy. And then the vegetations or the growths of the organisms are shown right there. This is an echocardiogram. Before I kill myself here. Here's an echocardiogram. They can be done transthoracic or transesophageal. I think you mentioned that in your presentation, Heather. I've actually seen one of these live. It's really cool to see an endocarditis live on a TEE because here's what is supposed to be flapping. This is a valve right here. It's supposed to be flapping back and forth, and you actually see it on a TEE. And then there's this little extension coming off the valve. That's actually the vegetation that's flapping along with the heart valve, right? So that's a nice piece of, they call this clinical evidence of endocarditis, and we'll get into that on the next slide. I had to put that picture on there because I hate Duke basketball. That's the Duke team after they blew the 19-point lead against UConn. I know, I was so happy about that too. So Duke is actually important here in endocarditis because we have what's called the Duke criteria for the diagnosis of endocarditis by cardiologists, infectious disease folks, so on and so forth. So the Duke criteria were published in 1994. It's gone through 2 modifications in the last 3 decades. According to the Duke criteria, there's only one true reference or gold standard for diagnosis of endocarditis, and that actually comes from valve tissue itself, either extricated in surgery or done by autopsy, right? So if an organism is grown or detected maybe by molecular techniques directly from the heart valve, that is the pathologic or the reference standard for endocarditis. Now, we're obviously not always going to get heart tissue from a surgery or from an, obviously for autopsy. So then we have what are called clinical criteria. So Duke criteria, they really want tissue for a pathologic diagnosis, but in the instances in which you don't have that, we have what are called clinical criteria. So this could involve microbiologic findings. That's where we get into it. Imaging, we talked about the echocardiogram, and Heather talked about it before, as well as direct observation surgically, seeing vegetations upon surgery. So any of those 5 or so conditions would contribute what's called a major criterion toward a clinical means of diagnosing through the Duke criteria. Then we have a whole slew of minor criteria. And again, we don't have to have all these. I'll go through an example in a little bit. So back in the major criteria, we had to have at least 2 positive blood cultures. That's another reason why to do more blood cultures, and Heather was kind of getting at that point as well. In the instance in which you don't have more than 2 positive blood cultures, that could satisfy a minor criterion toward the diagnosis of infectious endocarditis. Then we get into culture and serology, and then we get into a whole mess of clinical findings such as fever or some sort of immunologic phenomenon such as rheumatoid factor, so on and so forth. So how does this work? If you don't have the organism from tissue, which would have been the reference method or the gold standard, here's a couple examples of how you can arrive at a clinical diagnosis of infectious endocarditis. So going back, you could have one major criterion plus any 3 of these minor criterion, and that could give you a definitive diagnosis of endocarditis by the Duke criteria. If you only have maybe 3 minor clinical criteria off of that list, it would be considered a possible diagnosis of infectious endocarditis by way of the Duke criteria. Now, they actually also in the guidelines list the typical pathogens that could be applied, I'm sorry I'm going back and forth, to either the major microbiologic criteria or the minor microbiologic criteria. And those are the pathogens there. And we're all familiar with these. No quiz at the end because we know all these pathogens. By the way, Deb's hay-sex organisms, which she's going to tell us at the end of a presentation, are also on that IDSA list. All right. Here we go. Myocarditis. Myocarditis is different. It's not infection of heart valve. It's actually infection of heart muscle, myocarditis, right? And it's most often viral in nature. We're really not looking for this much in the laboratory because we typically don't do viral cultures on blood, at least as far as I know. So the most common culprit in myocarditis is Coxsackie virus. And if anybody needs a review on your virology there, it's a member of the Picornaviridae. There's an easy way to remember that Picornaviridae is an RNA virus because the RNA is right in the name, right? Boom. RNA. What does pico mean? Think of your metric system. Really, really small, right? 10 to the minus 9, I think, or something like that. So it's a really small RNA virus. And it's actually kissing cousins of stuff like enterovirus, echovirus. I think you mentioned parechovirus in your present. This is awesome. So, and Hep A is in that. So it's, huh? We did not plan this. Not at all, not at all. We haven't spoken in, no, just kidding. All right, any questions on the clinical, how are we doing on time? Half hour, okay. Any questions on clinical presentations of stuff related to blood cultures? So your blood cultures are going to play a part in all of this stuff with the probable exception of myocarditis. All right, specimen collection. I'm probably not going to have to say too, oh, I will have to say something. Okay, so the basic, everybody knows how to collect blood cultures, right? We've done this before. Does anybody here collect blood cultures on a routine basis? Awesome. Okay, I'm going to have lots of fodder in the audience here. So I'm just going to mostly go through the theory as to why we collect blood cultures the way we do. And I always tell my students that the most important factor in the diagnosis of clinically significant bacteremia is volume of blood collected. So I'm going to show you a couple papers that prove that timing is not as important as volume of blood collected. So I always tell students again, this study is 43 years old and it still applies today. This is the first study that gets you your 2 or 3 sets of blood culture bottles. So they looked at about 282, this is done in Denver, they did about 282 patients with clinically significant bacteremia, and they assessed them on how many sets of blood cultures were necessary to detect their bacteremia. So about 90% of patients got it on the first set of blood cultures, and close to 99% got it on the second set of blood cultures. So that's really all you need is 2 sets. Some people go to 3, I'll mention this later, but 2 sets typically gets you all your clinically significant bacteremia. I brought my, the over-under on this is 3 for today. Right now I'm at 2. Okay, now, number of bottles, right? Remember a set is 2 bottles, so if you're collecting 2 sets, you have how many bottles? 4. We're doing well so far, it's after lunch. So the importance, oh, who had 3?
Everybody bet the over, right?
Yeah, take the over. Take the under in the Michigan-UConn game, but take the over on Erik dropping his microphone. Anyhow, so the additional value of having more bottles besides having more volume is the distinguishing between pathogens and contaminants, right? So in conditions of endocarditis, and remember, endocarditis is a continuous bacteremia, right? So we're shedding all the time from that infected heart valve. It would make sense that you have multiple positive blood cultures in endocarditis. So in patients with endocarditis, just about all of them, 100%, had multiple positive blood culture bottles. In bacteremias that were not endocarditis, you still see a pretty substantially high percentage of positive blood cultures as a function of number of blood cultures taken, but in patients who are considered to have contaminants, the number of positive bottles goes down precipitously after 1 or even 2, right? So one question I was looking for on the iClicker when you were doing your talk, Heather, is the timing of blood culture, positive blood culture bottles, or when it went positive. And I think I'll show you that a little bit later, right? So some labs will actually report what the timing of when that first bottle went positive. Anybody do that? You're Ryan, right? Kyle, sorry, Kyle. You do that in Stoughton? What's that?
I have a brother, Ryan, and I've been called that most of my life.
You know, we had a student that looks a lot like you whose name was Ryan. Maybe I got it. But you do that as well, Kyle?
Yeah, we did it at request of St. Mary's.
Okay.
Because they work our blood culture.
Was that a Dick Dern thing back in the day? Or Ray?
From Ray.
Ray Pazorski, yeah. Another retiree, probably enjoying life right now. Okay, so that's another value of doing multiple bottles. You know, it's hard to tell 1 bottle of coag-negative staph out of 2. Is that real? Do they have a fake heart valve? But if that 1 bottle of coag-negative staph comes out of 4 total, it's a lot easier to probably lean toward contamination on that, okay? All right, awesome. Here's the thing about timing. This was done at the Seattle VA a number of years ago, still applies today. They're wondering how much more you're detecting by doing the second draw later, right? So any second draw within 24 hours led to a 20% increased yield of bacteremia in this study. But then when they stratified the data by either same time draw or 10 minutes later or 2 hours later, there was really no difference in when that second blood culture bottle was taken, right? So for the convenience of the phlebotomist, I would always tell my staff, if there's a second set of blood cultures requested, you can draw it at the same time as long as from a different site, a second venipuncture site, right? If the order explicitly states, please do this 30 minutes later, yes, you have to abide by the order, but if there's nothing specified in the order, just draw at the same time as long as from a different phlebotomy site. It probably saves hassle for the phlebotomist too, right? Because, oh my God, gotta go down 4 doors down, then I gotta come back and get that second site. You can do it right away, and it gets you the same yield of bacteremia. So I just pretty much said everything there. Guys get 20 mils. You guys still do aerobic and anaerobic bottles, correct? So dump about 10 mils of blood into the aerobic bottle, 10 mils into the anaerobic bottle. Recommending 2 to 3 sets per 24 hours. Doing any more increases the chances of inducing a nosocomial anemia by sucking too much blood out of these individuals. And even if you suck all that extra blood out, it's not going to increase your yield of positive blood cultures because we saw 2 slides ago, 2 to 3 sets ought to get you close to 100%. Okay?
Question what you said there.
Yo, go ahead.
So, you've got a patient,
Oh my gosh, I do this at work all the time. All right.
So you said 2 to 3 sets every 24 hours. So if you've got a patient that's highly suspicious, but your first sets aren't growing, are you saying they should draw another set like the next day, or?
Yeah, most of these studies call a septic episode a 24-hour period. So when people are doing, say, quality assurance monitoring on this type of stuff, they will use the first blood draw as time 0 and then wait 24 hours and then call that another time 0 for assessing the next set of blood cultures. You understand? Do you understand that?
Yeah.
Yeah. I'm asking if I made myself clear. I should have said that. But they usually start over the whole septic episode thing after about 24 hours. Then it would be acceptable to do another 2 sets. That's probably good. That's probably good. Because somebody was talking about the increased number of blood cultures. There was somebody in Reedsburg, I think, who was talking about that.
Hayward, Haley from Hayward.
Hey, that's who it was. Yeah. So, I was wondering if that's just an increased census thing or if people are going gung-ho on getting 4 or 5 sets, which they shouldn't be doing.
It's our doctors order blood cultures on anybody that comes in the ER. It doesn't matter what your signs or symptoms are.
And they're not febrile?
Nope.
Oh, you're kidding.
Normal blood
If I'm giving you
pressure, normal
antibiotics, you're getting blood
respiration.
cultures. That's
Yep.
strep throat.
Anybody coming in gets blood cultures, urine cultures too? That's another overutilized test.
Only if it shows up in their urine on our side. Wow. But we have a new provider. If he's gonna prescribe blood culture for antibiotics, he's gonna do cultures. We had the same weekend, we had a strep and a gallstones that they do 2 sets of blood cultures on.
Oh my goodness. Okay, we can talk about that later. I don't know if I want to record myself talking about that too much. But I agree with your pain, Kyle, yes. All right, I'm not going to do that. Who uses ChlorPrep here? What do you do for babies or infants? ChlorPrep? Is ChlorPrep FDA cleared yet on neonates? I don't think so, is it?
No, it is not.
So do you use iodine or do you use?
They use iodine.
That's what I was trained. If you can't use ChlorPrep because of age indications, you go with the old school iodine, and then you go through that, right?
We use 3 alcohols because we don't have iodine, so we use
Okay.
3 separate alcohols.
And you went in a circle. Do you still go in circles or do you scrub like mad? I've heard both ways.
We're supposed to scrub like mad.
Scrub like mad. You don't have to go in a concentric circle. See, I'm so old. I was trained to go into. Why would I be espousing going in a concentric circle back in the old days? What does that do?
Pushing anything upward.
It pushes your coag-negative staph and diphthroids away from the phlebotomies, right? That was the old University of Iowa training back in the day. Okay, so we'll skip that. We know that. We know that. Blood culture bottles, right? Everybody familiar with these? So I tried to represent everybody semi-equally. That's the Back Tech on the left, the Back T Alert. Do they still look like that even with the Virtuo or whatever? Okay, and then the Versatrex on the right. So a lot of these, they're built a little bit differently, but a lot of the principles are still the same, right? You have a blood to broth ratio to kind of dilute the specimen a little bit. Does everybody have charcoal in theirs or resins in theirs? Probably. Why do we have charcoal or resins in there without me giving it away? Why do we have charcoal or resins in the blood culture bottles? Why? Why would there be antibiotics in there? Yeah, maybe they went into the cupboard 30 years ago and found that one pill of penicillin that's going to make them better, right? So there might be circulating antibiotics in there at the time of blood culture phlebotomy that may or may not decrease yield. So the charcoal is going to try to decrease that. There's also an anticoagulant in there. These things work a little bit differently. To my experience, this guy has the sensor at the bottom, which is a CO2 detector, right? So when there's metabolism of the bacterium in the broth, it's going to spit off CO2 and it's going to detect it that way. This one is based on headspace, right? A change in pressure in the headspace, either due to gases being produced by the bacterium or gases being utilized by the bacterium, right? So there might be changes in pressure. And if we have time, I'll show you those graphs later. Oh, here's another advantage of having resins in your tubes. What is this? By the way, this is a gram stain done at oil immersion. And nothing wrong with the tech either. What's that? It could be. Is that the normal size of an E. coli, Kyle?
In a backpack Pete's bottle it is.
Why? Do you know why?
No.
Anybody know why this E. coli is like 10 times the normal length? Lauren might know this. We did this in October of your senior year. I love having Lauren in it. This is awesome. Anybody know why this E. coli is 10 times the length? It's suboptimal antimicrobial dosing, right? So when this person takes the one pill of penicillin against a gram-negative rod, which you know it's not going to work, right? So in normal gram-negative rod cell division, the first step is to make the bacterium really, really long, and then it divides into normal size segments, right? So in suboptimal dosing, the organism is allowed to get really long, but the drug will prevent it from dividing into little normal size segments. So the microbiologists call this gram-negative rods on drugs, right? This is an E. coli on suboptimal dose. That might be what you're seeing in your PEDS bottle, because that patient may have gotten a little bit before the blood culture.
The gram-negative rods in anything, the Pete's bottles, when they go, they get real long, real fat. They're like 2-3 times the size.
Yeah, they can also form little blebs or little blips on them too as a result of yeah. Anybody else see this besides Kyle? Is it only found in Stoughton or is it found in the rest of the state? Yeah, it's everywhere. Don't worry, Kyle. All right, culture methods. All right, I'm old enough to, you remember these, Deb? Which ones did you have?
So we had the ones with the paddle.
The septichecks. Yeah.
And we had a kind that supposedly would take the antibiotic out in case they got the antibiotic before the blood culture was ordered.
Oh, really?
Yeah, and I just want to share that.
Yeah.
So the back check files that you had, when we used to go to the ER or whatever to draw, if the patient was halfway with it, they'd say, "You're bringing whiskey to me?" And it's like,
Yeah.
oh no. And it's like, well, what is it? And I explain to them, well, this is where we put the bacteria. If they're in the bloodstream, they really like broth in there, and they'll just grow and grow and grow. And hey, but
And what was the reaction to that? Or were they all gorked out by that time? Yeah. Yeah, I know, I hear you. So back in 1990, when I first became a microbiologist, this was like the standard of care, these guys right here, right? So blood culturing has really evolved over the last several decades, right? So in the old days, they would simply have bottles with broth in it. You stick the blood in there through a septum, of course, and then you would look for turbidity in the broth. That was your indicator that you may have a positive blood culture, right? There might be some gas production, there might be some pseudomembrane formation on the layer. And then the next, like I said, the next big advance was this septitech system. So it's essentially the same thing as that, but then you would open up the septum and you would screw a paddle on top there after I think about 2 days. when I was in college, it was my job to stick the paddles on top of the blood culture bottles. I did that for a whole summer, right? And then you tilt the contents of the bottle because these paddles had, I think, chocolate agar, McConkey agar, and tryptase soy agar on there, right? So you're going from a simple turbidity observation in here to actually getting colonies on there. And oh my God, I got a gram negative. That's a lactose fermenter. I got 3 things it could be, right? So that type of thing. And then you would work it up off the paddle, right? The obvious disadvantage of these guys is that you would have to blind subculture these things at the end of the incubation period. So when I was in college, that was my other job. Besides tipping or putting the paddles on, I'd have to do the blind subcultures. So I think we did those at day 2 and day 5, I think. Yeah, well, I still got it. Yeah, so you'd have to take every single blood culture that has not been reported positive yet and sub it to a chocolate plate and a CDC anaerobic blood plate, right? Was that nice and easy, or was that cumbersome?
Oh, it was just.
It was awful because you'd have to put alcohol on top of here and get a needle and a syringe together and all that crap, right? Just a pain. So then, oops, there's something else here. Anybody ever use the isolator system or hear of the isolator system? I'll just make a comment about that really quickly. They're not as available in the United States as they used to be. Isolator systems were largely housed at tertiary care medical centers. I saw one in Iowa City at my postdoc. The advantage of an isolator system is for intracellular pathogens, because the isolator system would actually take whole blood and lyse the cells. And the organism we were always worried about in Iowa City was Histoplasma capsulatum, because that's one that lives in macrophages, right? So if you lyse the organism or lyse the host cells, you can liberate the bacteria that might be intracellular and then put those contents onto plates. Worked great, got the histo out really great, but the problem is that there's a lot of hand manipulations that are done with the isolator system. And the more hands-on manipulations you get, what happens, do you think? What do you think happens? Contamination. So we got a lot of coag-negative staph out of there, as well as Histoplasma capsulatum. So probably more available in Europe these days than the United States, but that's a system as well. Okay. Then we have, oh my gosh, here we have the continuous monitoring blood culture system, right? This is kind of the standard of care today. We've had lots of discussions about this. Here's your 3 major manufacturers. Bottles that have sensors kind of go shooting in like that. And then these are often read, I don't know, every 15 to 20 minutes, right? And if there's a significant change in whatever parameter you're looking for, the instrument's going to go beep, 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 and tell you which blood culture bottle to pull. So Tim Block gave me these, and these are Versatrek. Anybody have a Versatrek? Okay, good. So these are Versatreks, and this is a system that looks at changes of pressure, right? So apparently this organism right here was releasing gases from its metabolism that caused the pressure to increase to a point where it went positive. And this organism also released gas that led to a positivity at that point. Another audience participation game, okay? Look at the x-axis. This is in days. This one is in hours. And I want you to match up the 4 choices on the bottom to the graph A or the graph B. Graph A will have 2 answers, the name of a potential organism and the number of positive bottles. And graph B will also have a name of an organism and a number of positive bottles. Everybody understand the parameters of this game? We have some conversations going on in the back. This is good. We have more conversations here. Lauren is scared that she's going to get it wrong.
Say that E. coli is going to come up at 10 hours.
Why is that?
Because the negative rods always come up very quickly.
That's right. And is E. coli typically a pathogen, or could it be a contaminant?
Typically a pathogen.
We had that discussion at the end, 1 out of 4. And I agree, 1 out of 4 with E. coli is probably a pathogen.
Yep, I would say that's E. coli, 4 out of 4 drawn, 10 hours.
Well done. Yeah, the actual retail price on here I think was 9.2 hours. It was ungodly quick on that one. Okay, which leaves us with what for A? What's the 2 answers for A? Coag-negative staph, and how many bottles? 1 out of 4. there's your value of collecting more bottles, right? You get increased volume, but the 1 out of 4 can help you differentiate a contaminant versus something that's probably more clinically significant. And these graphs show it pretty well. Good job. All right. Now sometimes, and I think you've experienced this before, you can have what's called a false positive blood culture. In the phlebotomy that you're taking, there might be some metabolically active still metabolically active cells that are getting into your blood culture system. They're pumping out CO2 as a result of their metabolism, and they're tripping this thing as being positive. You pull the bottle off, you don't see anything on gram stain, you're worried about Campylobacter. Let's do a carbofusion counter stain. Still nothing. Oh my God, let's do an acridine orange stain. Still nothing, right? So when you go through all those mechanisms, you put the bottle back in, and it's probably a false positive. Anybody experience this, or do you see this on a base? Everybody knows about this. Okay, preaching to the choir. All right. So we went through a lot of this. In the old days, positive blood culture bottle would get a gram stain. That's the first thing we would do. We would pull the bottle off, do a gram stain. In our lab, of course, that's a critical value, right? You got to call the floor, call whomever with that result. And then in the old days, you subculture it for ID and susceptibility. And then we talked a lot about what's happened in the last 20 years as far as molecular testing and stuff like that, right? Here's a study. How are we doing on time?
A little over 10 minutes.
10 minutes. I'm going to have to fly. All right. So here's a study published about 25 years ago that actually shows the tremendous value of that very first gram stain for a positive blood culture bottle. So in this graph, the time of phlebotomy is right here, and it looks like the actual act of phlebotomy is initiating vancomycin and ceftriaxone. CAX is ceftriaxone here. Then a positive blood culture bottle came off and you gram stain it, and it looked like as a result they switched from empiric therapy to more directed levofloxacin. Maybe they got a gram-negative rod out of there. I don't know, right? So there were 465 graphs that were viewed that way, and it turns out that in the 2 parameters that the laboratory has control over, in other words, the microbiology laboratory, in other words, the gram stain and the susceptibility, it turns out that more initiations compared to this happened as a result of the gram stain, right? So more initiations of therapy or more changes of therapy happened with that initial positive gram stain than with the susceptibility result 2 days later. Now granted, this was done 25 years ago before all this rapid molecular testing, correct? But it shows that that initial gram stain result can help guide therapy for clinically significant bacteremia. So we talked about what happens with outcomes. We had a great panel on that this morning. I'm going to skip that. Let's use Staphylococcus as an example, Staph aureus, as an example of how molecular testing can really benefit a patient, right? So in Fleming's day, that's Sir Alexander Fleming, we used penicillin for Staph aureus. That obviously doesn't work anymore. So then we moved up to nafcillin, but then of course, if you're MRSA, nafcillin is not going to work on that patient, and therefore quiz question, what's going to happen next? Vancomycin, very good. So that's basically your Staph aureus tree as far as bacteremia is concerned. Now, hypothetically, of course, you have methicillin susceptible Staph aureus and you have MRSA, methicillin resistant Staph aureus. Hypothetically, Vanco should work for both of those, right? Because, Lauren, there's only about 5 organisms that are gram-positive that are resistant to Vanco, the Pell organisms, right? And of course, Staph aureus doesn't fall into that. But keep in mind also that nafcillin will be good for methicillin susceptible Staph aureus and will not touch MRSA. Everybody agree with the ground rules for this game, right? Vanco covers everything because it's a really good empiric gram-positive drug. MSSA would be hit by nafcillin. Now, clinical studies have shown, now these data are specific to MSSA. Now keep that in mind. We're not doing MRSA right now, MSSA. Clinical studies have shown that MSSA bacteremia does not respond to Vanco, even though it's right here, as well as nafcillin. Okay? So it seems like nafcillin would be a better drug for MSSA. And when they tried to figure out why this happened, they did kinetic studies or growth curves on this MSSA. So here's the MSSA without drug, here's the MSSA with nafcillin, and here's the MSSA with vanco. It seems like nafcillin has better cidal activity against MSSA than does vancomycin. And that might explain the treatment failure rate that you were seeing in vivo in the patient. So wouldn't it be great to know early on that you had an MSSA? Why? What are patients being treated with when they first enter the big house for sepsis? Vanco, right? So you have an empiric drug on board, which allegedly is going to get everything, but may not do as well clinically if it's an MSSA, right? So if we had a molecular test that tells us it's MSSA, we could de-escalate the nafcillin, which has better treatment outcomes, right? And so the extra thing here added to this is a molecular test. I talked about an old school test that tells you MRSA versus MSSA versus a negative result, and then we'd still go back to growing it out and doing cefoxyfin susceptibility data, right? But your molecular test here gives you an opportunity to convert empiric vancotherapy to nafcillin if it happens to be an MSSA. What's the value of finding MRSA here? What would be the huge advantage of the molecular test in that situation if it turns out to be MRSA? What's that? You got them on vanco, so the treatment's probably where you want it to be. What's the other potential advantage there? Isolation. This might be the first indication that your patient may or may not need contact precautions, right? So that's another value of the molecular test. Very early, right? You could phone that the same time the gram stain gets phoned, perhaps. All right, contamination. Sandy Richter in Iowa City published a paper many years ago that talked about an algorithm that they used at the University of Iowa hospitals to deal with coag-negative staph in blood cultures. And essentially what they're doing is they're counting up the number of positive bottles of coag-negative staph versus the total bottles collected, and then they're going through an algorithm to figure out if we can just not do the susceptibility testing, right? So for example, 1 out of 4 bottles of coag-negative staph, and then they did chart review to correlate if this was really significant versus a pathogen. In coag-negative staph, they had 87.5% agreement between the clinical status of the patient and not doing susceptibility testing on 1 out of 4 bottles, right? So if you get a chance, take a look at that paper. If you don't have a system in your hospital to maybe streamline not doing susceptibilities on contaminants, that might be something to look into. So they did this for coag-negative staph, got the high agreement. They did this for Viridans group streps. They did this for the diphtheroids and got 87.5% concordance with a clinical status of the patient, right? Next thing. Oh, here's my opportunity to say you bet your asp. So this is antimicrobial stewardship programs. The big point I want to make about the rapid molecular diagnostic systems, right? We'd heard about that this morning. This would be like something over here for maybe a gram negative or additional gram positives. Those are your rapid diagnostic tests. They seem to have best effect when they're paired with the pharmacist, right? There's many papers in the literature that suggest that these systems work very well. They predict the pathogen very well, but as far as being used in treatment of patients, they have their greatest effect when you tell the pharmacist the result. Because those are the folks who are going to make the intervention in the empiric therapy and get them more to directed therapy. So yeah, you can spend all the money, you can work really fast to get the result in the computer, but no one's going to do anything with that of benefit unless there's a pharmacist intervention. So I urge you to incorporate your pharmacist into making these decisions. It's going to help the patient, and of course that's why we're here. Here's another paper that says the same thing. So there's a lot of things right here. This is a really screwy graph to look at. Even though it says negative right here, the more money you save is the higher bar, even though it says negative right there, right? So savings per death averted. Sounds pretty morbid, but it's actually a good stat for a hospital, right? So when you compare the rapid diagnostic testing by molecular means to the rapid diagnostic testing by molecular means with antimicrobial stewardship, you have more savings per death averted. Again, suggesting that you really have to incorporate your pharmacy stewardship people into the whole algorithm or thought process behind doing this. And here's another one that talks about that too. So these are mortality risks. The lower the number you are away from 1, the more people's lives you're saving, right? So you always want a number less than 1, so you're reducing the mortality, right? And again, you're suggesting that with stewardship, actually you're doing better for patient mortality rates. Okay. Here's an example of what a report could look like, what a fake report could look like, to kind of summarize everything we talked about today. So when I was directing the lab, we would always indicate the number of positive bottles and the number of bottles drawn, right? Because 1 out of 4 means a lot to folks compared to 1 out of 2, right? That helps there. We also talked about the time to detection. We always made that available on the report as well. Because remember that coag-negative stat that took like 4 days to come up on those growth curves, and Heather's E. coli came up in about 10 hours on that growth curve, right? So the quicker the time to detection, the more likely it is to be a pathogen. So that's why I felt it was important to do that. It's a critical value, so that gram stain result was a critical value, and we got the whole readback thing. Then we added a molecular test, one of those rapid diagnostic tests, that happened to look at gram-negative pathogens because of the gram-negative gram stain. And then it also had a slurry of resistance markers on here, right? Just because you have everything that's not detected doesn't mean you don't have resistance in that pathogen, because your panels aren't going to cover every resistance gene under the sun. So please keep that thing in mind, keep that fact in mind. So it looks like we have a Kleb pneumo. It sounds like the guy from Beloit that was in the front row. We got a Kleb pneumo with a CTX. That's your ESBL that the guy was talking about from Beloit in the Kleb pneumo. We didn't discuss that one in advance either. So then, so there's a comment here that we're going to subculture. We're going to do the full profile susceptibility. Oh, by the way, we called pharmacy about that because we know that our molecular diagnostic panels work best when pharmacy knows the results. So we called that. And then we did the full workup and the susceptibility testing. And oh, by the way, in that hospital, the ESBL profile was a critical value for infection control. So lots of business going on that report. And I think my last slide, believe it or not, final resulting for the continuous monitoring systems. The big difference here is that you do not have to do blind subcultures anymore, right? That's the huge advantage of your community, besides the time to detection, all that good stuff. So just hold it for 5 days. There are providers that will want you to hold them for like a week or 2 weeks. If there's a suspected Hay-Sec organism or a brucella, they'll ask you to hold it for 2 weeks. And I think that's it. So we're done, right? We got it done in time?
Timed that one perfect.
All right, any questions from the crowd? This is fun. Now we're not gonna leave until Deb tells us the Hay-Sec organisms. Let's see if she's still got it in there after 47 years.
It probably was something after I retired.
I know. So Haemophilus aphrophilus, Actinobacillus, Actinomycetium contents. By the way, they're now Aggregatibacters instead, because oh my God, there's a name change. Cardiobacterium hominis, Eikenella corrodens, the one that smells like bleach, and then the Kingella, the beta hemolytic one you often found in joints. Any other questions? This is fun. Yeah, you'll be recorded for posterity. And if you have any other suggestions as to what we could do for a breakout session at another later conference, we'd love to hear it because we value your opinions. We go through these sheets every November when we meet.
Have evaluations, please, if you have ideas, we would love that.
Good or bad, we don't care. We'll take all comers.
As long as you're having fun, right?
All right. Thank you very much.